Today I'm going to try to answer some neurology board questions, and I haven't done this since I took the boards in 2013, so it should be interesting. Let's have some fun. A 52-year-old man presents with a 6-month history of gait difficulties attributed to leg weakness, described as a feeling of stiffness in addition to weakness. This combination manifests as difficulty with tasks such as walking downstairs, rising from a seated position, or getting up from a kneeling position. He describes similar feelings of fatigue in his upper extremities, although he denies fatigability. He decided to seek medical attention due to the recent development of ptosis, drooping eyelids. Review of symptoms reveals a dry cough, dry mouth, constipation, and erectile dysfunction. So that could be a clue that there's something systemic going on. Examination reveals mild ptosis bilaterally with left eye affected more than the right. He demonstrates mild weakness of hip flexion with difficulty rising from a seated position without the use of his arms. He is unable to hop on either foot. Reflexes are absent at the ankles and diminished elsewhere. Electrodiagnostic studies reveal reduced motor amplitudes with relative preservation of sensory response amplitudes. So it's primarily motor. Slow 3 Hz repetitive nerve stimulation reveals a decrement. 10 seconds of maximal voluntary contractions elicits an increase in the amplitude of baseline motor responses. So that's seen in Lambert-Eaton syndrome. Which of the following is the most appropriate next diagnostic step? So the voltage-gated calcium channels are and chest CT, because it's probably Lambert-Eaton syndrome, myasthenic syndrome, which is associated of like a carcinoma, like small cell lung carcinoma, and he has a cough. And that looks like it's correct. Okay. In the prevention of migraine, which of the following tricyclic antidepressants has the least sedating effect? I believe the answer is nortriptyline. This is like most commonly used in the elderly. Amitriptyline is more sedating. The others are not used nearly as common. Ooh, not correct. Okay. This is not a drug I've ever prescribed in my career. Protriptyline. Let's see what they say. Protriptyline is the least sedating. Okay, I did not know that. A 35-year-old female presented for evaluations of convulsive episodes. These started about 3 months ago with apparent loss of consciousness, where she will lower to the ground and then experience shaking of the whole body for several minutes. Afterwards, she would usually be tearful, but there would be no distinct post-ictal symptoms. So this is typical of like a functional neurological disorder, like a pseudo-seizures. She has never experienced loss of bowel control or tongue biting or major injuries. Okay, so they're trying to explain this as non-epileptic seizures. There is no history of risk factors for epilepsy. Family history is also negative for epilepsy. She had been started on an anti-epileptic drug by her primary care physician without any improvement. She was then referred for video EEG monitoring. The study captured several spells with no EEG correlate, so she's convulsing, but the electroencephalogram doesn't show a seizure, and we're convincing for non-epileptic events. You discuss the findings with neurology residents on rounds. What is the most appropriate recommendation? Instruct the resident to inform the patient that the study was negative and she has pseudo-seizures. So it's better not to use the term pseudo-seizures because it can be considered somewhat derogatory. No follow-up needed, because non-epileptic seizures are resolved. That's not true. Send them back to their primary care physician. No, you should follow these individuals. Discharge from the epilepsy monitoring unit on psychotropic drugs, not necessarily. Arrange for psychotherapy as part of a comprehensive psychological follow-up program. Absolutely. Okay. A 2-day-old baby boy presented with poor feeding, lethargy, and convulsions. She had recently been discharged from the hospital in a healthy state just 24 hours prior to the onset of symptoms. Mother noted that the symptoms started after several feedings with the baby formula at home. So this is typical of metabolic disorders. Upon examination, he was hard to arouse and was hyperventilating. Laboratory workup was positive for markedly elevated alanine aminotransferase. Also, ammonia level was 900, very high. Okay, so this is probably like OTC maybe. Okay, workup for the infection was negative. Chemistries revealed normal serum bicarbonate, plasma amino acids, and quantitative urine organic acids. Testing showed normal levels of orotic acid in the urine and low plasma citrulline. So I think this is ornithine transcarbamylase deficiency, and it's in a baby boy. And so this is an X-linked disorder. Which enzyme defect is the most likely cause? So I believe ornithine transcarbamylase. And that is correct. Yeah, basically, a lot of disorders of metabolism, they don't show up until a little bit later because your mother is sort of doing your metabolism for you when you're in the womb. Okay, a 58-year-old accomplished violinist has been able to play for many years despite a long-standing tremor, but more recently he has trouble with control of his bow arm. He can make use of vibrato to compensate, but reports having difficulty with control of this as well. When prompted, he admits he was also having more difficulty with general functioning, reporting increasing head movements at baseline and shaking when he is holding music or conducting. His father, also a conductor, had a similar tremor. Examination reveals the tremor has both postural and kinetic aspects, which is apparent when the patient holds a piece of paper in an outstretched hand with finger testing. Okay, so probably he has a central tremor. He has mild horizontal head tremor, but this subsides when he is supine. He asks about therapeutic options, recalling that his father took propranolol and primidone for his tremor. Because the therapeutic effect of these medications did not outweigh the side effects, the patient is reluctant to use them. He also reports having difficulty control asthma, so propranolol wouldn't be good for him. Okay, which of the following therapeutic options is least likely to be helpful? So gabapentin has been used in essential tremor. Thalamic stimulation. Deep brain stimulation can be used. I don't know about dorsal column stimulation. Topiramate, I believe, has been used. Klonopin may be very temporarily helpful. I believe the target of DBS is not the thalamus. Dorsal column stimulation seems crazy to me. That would be more for neuropathic pain treatment. I'm going to go ahead and guess E. And that is right. Okay, so they said the rest are legitimate treatments. I didn't know that the thalamus was the target of DBS in essential tremor. Okay, the tricky question. A 4-year-old boy presented with sudden falls. He has a history of complicated delivery with low APGAR score at birth and prolonged stay in the newborn ICU. History was positive for delayed developmental milestones. When he was 6 months old, he was diagnosed with infantile spasms and treated with adrenocorticotropic hormone, with gradual resolution of symptoms. Okay? By 3 years of age, he developed multiple types of seizures, so they're getting that he has Lennox-Gastaut syndrome. With tonic-clonic, myoclonic, and absence seizures, these seizures responded poorly to a variety of anti-epileptic medications. That's typical of Lennox-Gastaut syndrome. In the last few months, he started to fall frequently, resulting in facial injuries. These, quote, drop attacks occur without warning. No convulsive activity is noted, and he's able to get up within seconds and resume his ongoing activities. Drop attacks are pretty common in Lennox-Gastaut syndrome. Mother also noted frequent head drops when he'd be sitting in his bed or chair. These are also small seizures. From the following, choose the correct statement regarding these, quote, drop attacks. Hypsarrhythmia is the typical ictal pattern seen in the EEG. I believe that's not true. That's the background in children with infantile spasms. They are diagnostic of Lennox-Gastaut syndrome. I don't believe they're diagnostic because it can occur in other forms of epilepsy. They are associated with characteristic findings of the MRI of the brain. That's not true. There are various causes of this syndrome. They are only seen with generalized epilepsies. I believe that is true. They are typically seen in individuals with symptomatic epilepsies. I'm not sure about that. I think it can occur in idiosyncratic West syndrome. I'm not sure. But I think, yeah, if it's not a generalized epilepsy, you should not get that. And I'm wrong. Okay. So, let's see. So, Lennox-Gastaut syndrome, they can be seen in various other types of diseases. They can occur in the absence of any structural abnormalities of the brain. So I'm not exactly sure why symptomatic. I'm not exactly sure the rationale there. Okay, let's move on. It's tricky. Okay, besides physical and occupational therapy, which of the following agents has the best evidence for treatment of focal spasticity in patients with cerebral palsy? It's probably Botox if it's very focal. All of these can be used for spasticity, but if it's focal, Botox is good. Okay, that makes sense, and I have done that treatment myself. Okay, a 75-year-old male presents with a 6-month history of tremor in his left hand. He notices it mostly at rest and tends to disappear during movement of the arm. This would be typical of idiopathic Parkinson's disease. According to the wife, he has significant mood changes, and several times he has been paranoid about his neighbors spying on him. His examination is positive for seborrheic dermatitis and very subtle tremor of the left hand. So he has some behavioral changes also. There is no rigidity or bradykinesia. Strength, coordination, and gait are normal. Although limited, several studies have identified potential uses for brain imaging in the diagnosis of Parkinson's disease and related disorders. Choose the correct statement from the following regarding imaging techniques. Okay. An MRI of the brain can establish the diagnosis of idiopathic Parkinson's disease. No, that's wrong. It's usually normal. Functional MRI can distinguish between idiopathic Parkinson's disease and secondary causes. Possibly true. Usually PET scan is used. Okay. Positron emission tomography PET scan has been shown decreased activity in the caudate nucleus. That's not typical of Parkinson's disease. A DAT scan, this is what is typically used, differentiate between essential tremor and tremor in Parkinson's disease. Now that's the most true, I believe. A DAT scan can differentiate between idiopathic Parkinson's disease and atypical Parkinsonian syndromes. I believe that's true, actually. But I feel sort of more confident in D. I feel the most confident in D. And that is correct. Okay. So I'm going to assume that it cannot accurately discriminate between different Parkinsonian syndromes. Okay. A 52-year-old man with a history of alcohol abuse presents after a fall. He can say his name and that he is at a hospital with prompting only. Exam is otherwise unremarkable. Results of laboratory testing show the following. Sodium 110, wow, very low. Okay, so normal is 135 to 145. Glucose 400, which is elevated. BUN 70, which is elevated. Creatinine of 2. So he has renal insufficiency. And blood alcohol 200, very high. Okay, head CT is normal. 2 days later, the medical ICU has difficulty weaning the patient from the ventilator. Repeat laboratory studies reveal sodium of 142. So it's dangerous to correct sodium rapidly because it can cause damage to the pons. Okay, glucose is better. Kidney function is better. Okay, neurology consult reveals a ventilated patient who can follow commands in the face, but not the extremities. So he has central pontine myelinolysis due to rapid correction of sodium, which is very dangerous. He has increased tone and spasticity in all extremities, but is unable to move them. Which of the following is the most likely explanation? Osmotic demyelination, so that's correct. Seizures, no. Wernicke-Korsakoff, no. Occult liver failure with cirrhosis, no. Anoxic brain injury, no. So basically, if you correct sodium rapidly, it can damage the pons due to osmotic demyelination. So you're supposed to correct it very gradually, no more than 12 milliequivalents per 24 hours, and you're supposed to frequently check sodium, and that is correct. Okay. A 40-year-old woman presents with a history of migraines. Her MRI scan is shown. Which of the following is the most common clinical presentation of this abnormality? Okay, so this is most likely a cavernoma. So bleeding, acute intraparenchymal hematoma, not really. Subarachnoid hemorrhage, not really. Seizure, not really. Focal pneumonia, okay. Probably seizure is the most common, actually, would be my guess, rather than the focal neurological deficit. I'm not 100% sure. There's a vision loss one I know. Probably the answer is seizure, because they don't bleed that often. Let's see if I'm right. Yeah, I'm right there. Okay. Seizures, 30%. Intracranial hemorrhage, only a little bit less likely, 26%. Okay, a 51-year-old man who presents with long-standing insomnia reports trouble falling asleep most nights. He tosses and turns and often cannot fall asleep for hours. On those nights, he reads on his laptop until he falls asleep from exhaustion, so he has very poor sleep hygiene. Which of the following statements offers the best advice for improving quality of his sleep? If unable to fall asleep immediately, stay in bed without activities until you fall asleep. No, you're supposed to get out of bed. Okay, avoid short naps. That's probably good advice. Exercise in the late evening. You don't want to exercise too late. Okay, exercise, no. Avoid yellow warm light when using electronics. That's probably true. Although it's usually more the blue light that you want to avoid. So this is not exactly correct. Use the bedroom for sleep and sex only. So yeah, this is good sleep hygiene. So I think this is the correct advice, that just you have to associate your bed with sleep. And that is what they were getting at, sleep hygiene. Yeah, okay. All right, a 36-year-old man who presents with a history of frequent headaches describes a squeezing or pressure sensation in a band around his head. The headaches first started when he was in college, but he now has up to 3 a week, lasting 1 to 3 hours. The pain is often worse when he is exposed to light, but he has not noticed any sensitivity to noise. He has no associated nausea or vomiting, and he has had to curtail normal activities or miss work. He currently does not take medication for the headaches. Which of the following medications should be recommended first? Okay, so likely migraine, but more like tension headaches because maybe he only has a little photophobia. So caffeine and butalbital, that would be more for migraine. Ibuprofen, baclofen, and aspirin. Butalbital and acetaminophen, gabapentin. So I think that they're going for these are more like stress-related tension headaches because he doesn't have a lot of migrainous features. So maybe they're getting it baclofen and aspirin, or I mean, it's a little bit, certainly ibuprofen would be completely fine. So probably it's not likely to be anything with butalbital. Definitely not gabapentin. So it's probably one of these two. It's hard for me to say that there's one standard treatment, Probably, I personally, I would probably give ibuprofen, but I don't want to overthink it. I would probably just give ibuprofen, but maybe they're getting at C. I guess right. Okay, tension type headache. Okay. It's hard to say that that's objectively the right answer. Okay. An 87-year-old woman who has a history of rheumatoid arthritis, hypertension, varicella zoster, and unspecified memory disorder is brought to the emergency department by adult family members. They report she seems more disoriented and less alert compared to several days ago. Staff at her assisted living facility report she has had minimal food and drink for the past 3 days. She appears uncomfortable and has her hand on the right side of her head and states repeatedly she has a headache but is unable to describe the pain. She has a temperature of 100.6. Which of the following is the most likely diagnosis? Okay. So it could be giant cell arteritis. She has headache and fever. Sinus headache, she probably wouldn't have fever or excruciating pain. New onset migraine in an 87-year-old is crazy. Sunk syndrome is short acting. So, and it's not very unlikely to be a trigeminal loss. So probably giant cell arteritis would certainly be what you're concerned with. Yeah, okay, that makes sense. All right, a 60-year-old male presented with new onset generalized tonic-clonic seizure. Upon examination, he had right hemiparesis with brisk deep tendon reflexes and a positive Babinski sign. MRI of the brain revealed findings similar to the ones shown in the image. Choose the correct statement from the following with regards to treatment plan for the most likely diagnosis of this patient. Let's see. Ooh, this is likely a malignant tumor with a cystic component. Okay. With a lot of brain mass. So this could be like a glioblastoma multiforme. Okay. The extent of tumor resection has no impact on survival. That's not true. Complete en-bloc resections extend survival. Combination therapy with Temodar with radiation does not have additional benefit with radiation alone. No, I think Temodar is used. Bevacizumab, which is an anti-VEGF blocker for edema, has been shown to prolong the overall survival rate in these patients. I believe that's true because this is probably a GBM, a glioblastoma multiforme. Okay, well, this is what John McCain had. So methylation of the promoter for 0,6-methylguanylene DNA methyltransferase is predictive of improved survival outcome with chemotherapy. I'm not sure about that. Okay. Addition of tumor treating fields to Temodar has not been shown to improve progression-free and overall survival in these patients. I mean, I know I'm most confident in is C. Let's see if I'm right. No. Okay. So, yeah, I wasn't too familiar with this gene. So, glioblastoma multiforme. Okay. High-grade gliomas, treatment, radiation. Okay, the 0,6-methylguanine DNA methyltransferase gene encodes a DNA repair enzyme which can counter the effect of chemotherapy and radiation therapy by repairing the DNA of the tumor cells. DNA methylation is a mechanism to control gene expression. Patients with MG-MT methylated tumors have a better prognosis. Okay, I did not know that. 32-year-old woman presents with a 2-day history of diplopia she initially attributed to fatigue, so did not seek medical attention. She denies headache, nausea, or vomiting. Examination reveals no issue with rightward gaze, but with leftward gaze, so she looks to the left, her right eye fails to adduct, so she has a left internuclear ophthalmoplegia, and there's horizontal nystagmus in the abducting eye. Her pupils are equal, round, and reactive to light. Visual acuity is normal. MRI of the brain with and without contrast are shown, which is the most likely diagnosis. She has a lesion right in the center of the midbrain near the medial longitudinal fascicula. So this could be seen, for instance, in like multiple sclerosis. Probably not head trauma or stroke or tumor. Probably multiple sclerosis would be the most likely. 2-day history. And she's only 32 years old, so multiple sclerosis would be most likely, yeah, just based on age and risk factors. Okay, a 19-year-old student who briefly lost consciousness following head impact with another player on an athletic field reports persistent difficulty concentrating, planning study assignments, and deciding on answers during multiple choice examinations. His MRI has shown the most appropriate course of action is... So let's see, the MRI looks completely normal. Okay. So avoid psychoactive prescription medications. There's no specific reason for this. Okay, do nothing further because MRI is normal. That's probably not correct. Initiate comprehensive biopsychosocial rehabilitation. That could be effective in post-concussive syndrome. Prescribe an anti-epileptic. No, that's not done routinely. Take antioxidant supplements. I'm not sure if there's any evidence of that, so probably the answer would be C. Yeah, okay. So he meets the criteria for traumatic brain injury because he has ongoing social occupational dysfunction. Okay. A 20-year-old female college student who presents with chronic daily headaches has a long history of migraines with aura that seem to increase in frequency once she started college. She now has chronic daily headaches in addition to migraine. She takes 600 milligrams of ibuprofen and one combination pill of butalbital, acetaminophen, and caffeine daily. And so she essentially has chronic analgesic overuse headaches. So if you use a lot of these over-the-counter medications and prescription medications, you can get these more chronic migraines. She states the pain temporarily improves with the medication, but she feels it again as soon as the medication wears off. She states she also feels very anxious and irritable, but attributes these feelings to her headaches. Which of the following is the next best step in management? So usually you would give a prophylactic treatment. Although if someone has chronic headache, you usually get some kind of imaging study. So MRI of the brain with and without contrast is probably warranted, actually. So triptan is not great for chronic headaches because she's going to use them all up very quickly. Stop the ibuprofen and combination pill. That may be very reasonable, actually. Add amitriptyline. A lumbar puncture would not be needed. So probably amitriptyline is what they're going for. I would also get an MRI for chronic migraines, chronic headache. That does not go away. So maybe that would be the first step, actually, to do that. Although they may be going for D. I'm not sure here. And they actually say C. So, okay, that is a legitimate treatment. So medication overuse headache, so stop the offending agent. It's a little bit confusing there because typically, even if I suspect the diagnosis of chronic migraine, if someone has a headache that doesn't go away, I do think imaging is warranted. Okay, 71-year-old man sustains multiple traumatic injuries in a high-speed motor vehicle crash. He is intubated and his cervical spine is immobilized at the scene. Trauma workup reveals an injury from C4 to C7. Vital signs are as follows. Blood pressure is low, 90/60. Heart rate 40. Temperature 98.6. He does not breathe over the ventilator. Which of the following is the next best step in management? So central line, fluid bolus to treat hypotension. Corticosteroids is probably reasonable. Decreasing the rate of the ventilator no, you wouldn't do that. Okay, continuing general critical care support. So hypotension can worsen cord injury, so probably just giving fluids would be the most immediate thing to do. Although, yeah, I mean, assuming you have a central line is likely also warranted, but it's hard to say which is more urgent. I guess I would just give IV fluids first. And that is what they were going for. Okay, neurogenic shock. Okay, yeah, that makes sense. Get the blood pressure up. Okay. After reading an article reporting that 10 to 20% of older adults older than age 65 meet the clinical criteria for a diagnosis of mild cognitive impairment, a 68-year-old woman seeks neurologic evaluation for occasional forgetfulness. Which of the following cognitive functions is most likely to represent normal aging rather than the possible emergence of a cognitive disorder? Probably the answer is anomia, inability to name things. So visual hallucinations, no. Need for assistance with activities of daily living is not normal. Change in personality is not normal. Poor sleep quality is pretty normal. Decline in ability to manage finances is not normal. Probably poor sleep quality is typical of normal aging. And it looks like that is right. Okay. A 52-year-old woman is admitted following recent development of painful distal lower extremity numbness and tingling. Results of a complete metabolic panel, B12, and serum protein electrophoresis are negative. That's sort of standard dementia and peripheral neuropathy workup, I should say. The patient is subsequently referred to an urgent neurology clinic after developing a gait disturbance and balance difficulties. She reports the numbness and painful tingling have progressed to the upper extremities. Neurologic examination reveals weakness in both proximal and distal muscles of all extremities. Deep tendon reflexes are absent. Electrodiagnostic studies reveal diffusely low amplitude compound muscle action potentials with preserved distal motor latencies and conduction velocities. Okay, so some kind of peripheral neuropathy likely. Which of the following statements regarding the patient's diagnosis is true? Painful peripheral neuropathy. Okay. The results of the electrodiagnostic study confirm the diagnosis. No. CSF analysis is not needed if the presentation is classic. So maybe they're getting at chronic inflammatory demyelinating polyneuropathy, possibly. That would certainly go with this. The prognosis is better in patients with AMSAN than those in AI. No, that's not true. Okay, antibodies directed at ganglioside, particularly GM1, are seen in patients with AMSAN. That may be true. GM1 is linked to a lot of diseases, including CIDP. This is acute motor and sensory axonal neuropathy. Okay, patients with AMSAN are safe to admit to a floor unit. Probably not, because they can often have respiratory symptoms. So this is not true. This is not true. It doesn't confirm the diagnosis. You would want to do a spinal tap. It's actually worse. So probably anti-GM1 antibodies are associated with AMSAN, I believe is correct. Yeah, there we go. So it's a variant of Guillain-Barré syndrome. I guess it's not necessarily chronic because it doesn't say the timing. Okay. Tricky question there. Okay. In a patient taking both neuroleptic and serotonergic medications, which of the following clinical findings is most likely to distinguish neuroleptic malignant syndrome from serotonin syndrome? So I think altered mental status, you can have it both. Hyperthermia, I think you can have it both. Autonomic instability, I want to say myoclonus is more typical of serotonin syndrome. Yeah, I'm not 100% sure about that, though, but I'm going to guess, I believe myoclonus is more specific to serotonin syndrome. Let's see if that's correct. No, it is not. Elevated creatinine kinase. Okay. Is a cardinal feature of neuroleptic malignant syndrome that can lead to rhabdomyolysis. So I didn't know that was specific to neuroleptic malignant syndrome. Okay. All right. A 29-year-old man with a history of relapsing remitting multiple sclerosis presents with a 2-day history of leg weakness. He was diagnosed 2 years ago when he presented with lower extremity paresthesias and diplopia, which is double vision. At that time, he was started on a course of interferon beta 1A, but optic neuritis developed in the left eye. Within 9 months of beginning treatment, the condition eventually resolved and his vision improved from 2100 to 2040 in the left eye. 3 months later, an episode affecting the brainstem occurred, manifested by right internuclear ophthalmoplegia and vertigo. He was treated with steroids and made a good recovery. His baseline symptoms include fatigue, neurogenic bladder, and poor balance. He uses a walking stick for a long walk. His current MRI scan shows 4 new T2 lesions in the brain and 2 enhancing lesions in the cervical spine. So basically his treatment is not working. Which of the following statements about his condition is true? Interferon therapy should be continued given its good safety record and a few mild relapses that should be permitted. That's not correct. Symptom development while on first-line treatment is a potential sign of active disease. Therefore, treatment should be escalated. Of course. Monthly IV steroids infusions are indicated. That would be an old-school treatment that's no longer routinely done. The patient should be monitored with MRI scans. That may be true, but it's not really the best answer. Treatment should be escalated only if there's confirmed progression of disability. No, you would take relapses and new lesions very seriously, so it must be B. Okay. A 41-year-old woman with a history of lupus nephritis undergoes a successful kidney transplant and is started on tacrolimus to help prevent organ rejection. 2 weeks postoperatively, she develops headache, visual field loss, and confusion, followed by a generalized tonic-clonic seizure. The patient is brought to the emergency department where she receives levetiracetam and lorazepam. Her MRI is shown which of the following is the most likely diagnosis. So this is PRES, Posterior Reversible Encephalopathy. Okay. Syndrome. Okay, yeah. Calcineurin inhibitor. Yeah, this is associated with tacrolimus. Let me just take a look at the other words. Not occipital stroke, herpes. Nah, okay. Pretty straightforward there. Okay. An 8-year-old boy presented for consultation regarding management of a generalized tonic-clonic seizures. His first seizure occurred at 3 years of age and subsequently about once a year. All his seizures occurred in association with high fever except the last one, which occurred a week prior to this clinic visit and was not related to fever. At least twice, he had more than one seizure in one day. He has an older sister with a similar history. His mother remembers being told by her parents that she had seizures with fever as a child. Neurological examination is within normal limits. Lab work and EEG is non-revealing. You obtain genetic testing, which reveals a mutation in the SCN1A gene. You decide to proceed with prophylactic treatment with anti-epileptic drugs. Which will be the most appropriate drug? So febrile seizures increase the risk of generalized seizures. Usually febrile seizures are only between 6 months and 5 years of age, like simple febrile seizures. So which is the best drug? So SCN1A, I know, is a gene that predisposes generalized seizures, so you probably would not give carbamazepine and oxcarbazepine because these are more used for partial seizures. Lamictal is more used for like temporal lobe epilepsy. So probably phenytoin or valproic acid. I really have no idea which one would have the better evidence, so I'm essentially going to have to take a 50-50 guess. Probably valproic acid has worse side effects, so maybe phenytoin would be more appropriate. Although I think maybe this type of mutation, you want to try and avoid sodium channel inhibitors somehow. I'm going to guess valproic acid, actually. Let's see if I'm right. Wow, I guess right. Okay, so this is guess. Okay, I didn't really know the name of this because I'm not a pediatric neurologist. And I guess I guess valproic acid is the treatment of choice. I'm curious if they say anything about phenytoin. Not really. Okay, you should avoid anti-epileptic drugs with sodium channel blocking effects. So I actually did know that. Okay, perfect. An 80-year-old woman who presents with a headache is blind due to earlier occipital lobe hemorrhages. She lives in a locked dementia facility at baseline. Vital signs are as follows: blood pressure a little elevated. Her MRI scan has shown which of the following is the most likely diagnosis. So she has little hemorrhages all over. So probably amyloid angiopathy, most likely. That's probably what they're going for. Probably cerebral amyloid angiopathy would be correct. Or are they going for untreated hypertension? Probably not. I mean, these are a lot of different microhemorrhages. None of these really make sense. Yeah, okay. All right, a previously healthy 35-year-old man presents with acute chest pain and difficulty breathing after a party. EKG shows ST elevation, and his cardiac troponin is elevated, so he's having a heart attack. Okay, while the cardiac team mobilizes, the patient suddenly develops left-sided weakness. MRI scan has shown which of the following is the most likely diagnosis. So there's an infarct here on the right side in multiple vascular territories. How do I get off here? Okay. And it looks like there's a right MCA occlusion or severe stenosis. Okay. All right, so carotid artery dissection. So maybe, yeah, carotid artery dissection would probably be the most likely. Cocaine-induced vasculopathy. Well, it doesn't say he used cocaine. Yeah, could be. I mean, he has a heart attack also. Okay, so obviously conversion syndrome and migraine with aura are wrong. I mean, I guess he's having a heart attack and an acute stroke. It's probably not, and it's right after a party, so I think they're going with cocaine-induced vasculopathy, most likely. Because they're not showing evidence of a carotid dissection. Let's see if that's right. Yeah, that's right. Okay. That makes sense because he had a heart attack and stroke at the same time. A 72-year-old man presents with bilateral fluctuating ptosis and dysphasia. His wife notes his eyelids droop when he is reading, and he admits that he has affected his ability to read at night, although he is typically able to read early in the day without difficulty. He also reports problems eating, stating that he tends to pocket food in his cheeks, so he has some facial weakness. Worse on one side than the other, but variable in both extent and side affected. Okay. He also has more profound fatigue, especially at night. He can no longer work in his wood shop for more than 10 minutes before needing to rest. Examination reveals a hypophonic voice with a nasal quality, asymmetric ptosis, and facial weakness. So it sounds like he has a neuromuscular junction disorder, most likely, and mild global weakness. He becomes breathless with sustained counting and demonstrates fatigue with both neck flexor and neck extensor testing. Binding acetylcholine receptor antibody is positive, so he has myasthenia gravis. Slow 3 Hz repetitive nerve stimulation reveals the following result. And so this is a decrement with repeated nerve stimulation, I believe. Okay, so what is the answer here? So if pyridostigmine should be only used if immunosuppressive therapy is not effective? No, you can use both. Thymectomy should only be offered to those patients with thymoma. I'm not 100% sure about that. There may be some evidence with thymic hyperplasia that it can be effective. Okay, non-steroidal immunosuppressive agent can be used alone when corticosteroids are contraindicated or refused. That's certainly true. There is good evidence supporting the use of mycophenolate over azathioprine or cyclosporin as a non-steroidal immunosuppressant agent. I don't think there's any specific evidence for that. Corticosteroids should be used to manage a patient presenting with impending respiratory failure. No, steroids are specifically contraindicated in myasthenic crisis. So I believe that C is a reasonable answer. Okay, there we go. All right. Which of the following statements about rapid eye movement sleep behavioral disorder in Lewy body disease is true? So Lewy body disease is like a Parkinsonian disease that can cause this unusual sleep behavior. So it is more common in women than older men. I don't think that's true. Polysomnography shows rapid eye movement and atonia, no atonia because they have these abnormal movements. Hyposmia or constipation may be present. I'm not sure about that. A postural tremor that resolves at rest is often present. Dream content is typically tranquil or placid. That's definitely not true. I guess constipation would be very common. I'm not really sure. And loss of smell is common. So I'm going to guess C is definitely associated with this. Yeah, there we go. Okay. All right, neurologic consultation is requested for a 42-year-old man who was admitted to the ICU following cardiac arrest. Family members started CPR at home, but he was found to be in pulseless electrical activity arrest when EMS arrived. An EKG tracing was performed during transport, and he required intubation and ventilation before ICU admission. He remained unresponsive, intubated, and ventilated, and recently began exhibiting frequent and sometimes violent myoclonic jerks. At first, these occurred with tactile or auditory stimuli, but they eventually progressed over the next several hours and now occur spontaneously. EEG demonstrates epileptiform discharges that correlates with clinical jerks using concurrent electroencephalography, electromyography, polography. Which of the following statements about this patient is true? So it's unclear. Is he waking up is the key thing. So you can get this with Lance-Adams syndrome upon awakening, but it looks like he's unresponsive and intubating. So this is like severe anoxic injury. Okay, severe post-hypoxic myoclonus is generally responsive to monotherapy. I don't think that's true. It's hard to treat. Okay, agents used to treat positive myoclonus are generally effective against negative myoclonus. I don't think that's true. Valproic acid, Klonopin, sodium oxybate have not shown efficacy in treating post-hypoxic myoclonus. No, I think they can be used. Keppra should only be used if there is concern for seizures. No, you can treat myoclonus with Keppra. Screen for metabolic derangements should be performed. Of course, that's true. I think just by elimination, E is the correct answer here. And it looks like everything else is not correct. So by elimination,